Hey everyone, it's Matt Fox here from Free Associations. We've got a really good show coming up for you in which we are looking at a study around the impact of male circumcision and HIV treatment on HIV incidence in Uganda. Before we get into the show, when listening to it over, there are a few corrections that I wanted to make before we get into it. First one is that you'll hear in the audio that Don is sort of describing the background of HIV prevention efforts in around the world, really, and you'll hear him say that condoms are so-so, and I just wanted to be extra clear that what he means by that is our ability to get people to use condoms is so-so. Condoms are incredibly effective at preventing HIV. Also, there is a point at which you'll hear Chris refer to a hypothetical scenario in which circumcised men are uninfectable. And you'll hear sort of me vaguely in the background trying to say less infectable because, of course, circumcision has been shown to reduce the incidence of transmission to men. It doesn't protect completely against it. The bigger one I wanted to get to is an issue that a correction that you'll hear me say several times in the podcast. I referred to the analysis of the study as ecologic, or sort of a hybrid of a patient level and ecologic analysis. And the more I thought about that, I realized that's not really accurate. So it isn't an ecologic study. It's a cohort study just using an ecologic or using a population level variable as one of the predictors. So I just want to make sure that's clear. And lastly, in our second segment, you'll hear that we talk about the difference between efficacy and effectiveness. And I just coincidentally, there was a tweet from Miguel Hernan that went out that actually addressed the usefulness of the distinction between efficacy and effectiveness just yesterday or the day before. And so I just wanted to point readers to that because it's a really interesting discussion. Go and find Miguel's Twitter page and you'll find that. So that's all. And now on to the show. Welcome to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who's questioning that big new medical breakthrough. I'm Matt Fox, professor of epidemiology and global health. I'm here in the studio with Don Thea and Chris Gill from the Department of Global Health. And we are, as always, in the Boston University Godley studio. Before we get started, we want to take a second to remind you about Population Health Exchange, the Boston University School of Public Health's resource hub for lifelong learning. Find out more at www.pophealthex.org. That's www.pophealthex.org, where you'll find this podcast as well as many other population health learning programs and tools. And as a reminder, we cannot beg you enough to go on and hit that rating button on your podcast app, or to go onto the website and give us a review. Let people know what you think about the podcast. That is how people are going to find us.
Unless you really hate us. In that case, we're encouraging
I want to hear
inaction.
about them too.
Well,
I want to hear from them.
Maybe so if you hate us, then send a direct message to Don. Otherwise, you give us a review. So now,
Can we give him his phone number?
I would
please don't.
rather we left that off because it might happen to me at some point. All right. So today in our first segment, our Journal Club segment, we are going to get into a study that looks at whether or not using multiple means to prevent HIV infection is actually effective at reducing the overall infection rate. In the second part of our podcast, which is our deep dive segment, we will get into the difference between efficacy and effectiveness studies. And then in our third segment, our amazing and amusing, we will get into some research that you probably haven't heard about, or Chris will define a new Latin phrase for us. So let's get into it. In our first segment, we are going to get into a paper from a group that's been working in Uganda for a long time. And the paper looks at whether or not combination HIV prevention, which is a big thing now in the HIV world, has been effective at reducing HIV incidence. The article was published in the New England Journal of Medicine. It is entitled HIV Prevention Efforts and Incidence of HIV in Uganda, with lead author M.K. Grabowski from Johns Hopkins School of Public Health. We should note that this one is a little bit in our wheelhouse in that all three of us do some work on HIV, and so we know a little bit more about this one than some of the others.
So we can talk semi-authoritatively about this, as opposed to everything else we've talked about.
Instead of completely making stuff up.
Yep. As always, let me give you some of the headlines. So the Independent says, Rakai HIV study shows remarkable drop in infections. Global Health Now says prevention pays off in Rakai. And the United Press International says U.S.-funded HIV prevention effort reaps rewards in Uganda. A little bit specific on that one. So Don, let me start with you. Can you tell us what they did in this study and what they found?
Sure. Want to give a little bit of background about the treatments that they provided in the study. We've made incredible progress in combating HIV, and we have developed really amazing tools that are really the subject of this particular study. And we've also learned that some interventions aren't quite as good, and the tools aren't quite as effective. For instance, the whole issue of abstinence has been a complete and utter failure, both outside the United States and essentially within the United States.
And I will say, I kind of feel like we should have known that one wasn't going to work.
Yeah, I think that was a little politically motivated. Condoms are sort of so-so, and other behavioral interventions are not so great. But what we now have are drugs that are incredibly effective and much easier to take and much cheaper to take than they were in the past. And so those antiretroviral drugs are so effective at decreasing the amount of virus floating around in the body that they, in fact, have been shown to affect an infected person's ability to transmit the virus. So if you are taking your medicines as you're supposed to, you have almost no virus floating around in your system, and therefore you really almost can't infect somebody else. But the caveat is that you have to be adherent, and the medicines have to be appropriate for your infection.
Not resistant to
and
the
they have
medications.
To be right. And they have, well, if they're resistant to the medications, then you would have a lot of virus floating around in your system. Yep. And this was established in a landmark study, 052, HPTN 052, where they followed a bunch of discordant couples in many centers throughout the world.
Meaning one partner has HIV, one does not.
Correct. And they continued to have sex, and they were advised to use condoms when they had sex. And of the 1,700 couples that they followed for, I forget how long it was, 2 years, something like that,
Yep.
They identified that there were 28 transmissions that occurred between the couples. And they identified that the virus actually came from the partner because they did a genomic analysis. And so they call them linked transmissions. And apparently only one of those linked transmissions came from somebody who was infected, part of the couple, and was on medication. So it was essentially a 75 to 90% reduction in transmission.
And do we know if that individual is non-adherent or had resistance?
I don't know. I don't know. We may. I haven't read that article recently. The other modality that we have is male circumcision, and we've known that for some time through observational studies. And there were a series of studies that were randomized controlled trials, which had to be. Two of them had to be finished early because the male circumcision was so effective in interrupting male to female transmission that it was unethical to
No. Backwards.
Female to male.
Roll that back.
That's right. Sorry, male to female. Sorry.
No,
female to male.
Female to male.
Right. Men who were circumcised were 50% less likely to contract HIV.
That's right. That's right. That they had to stop it early, and then that became sort of the standard of care. So what this study is trying to do is look over time at a very well-researched community, 30 communities actually in Uganda, as these interventions were introduced into the population. And what they did is they then followed the infection rate among a cohort of HIV uninfected individuals and counted the number of new infections. So the Rakai Community Cohort Study has been around for 12 years. And every year, what they do is every year and a half, they go around to these 30 communities within Rakai, and they enroll new patients or new subjects, or they follow subjects that have been enrolled relatively recently. And so they have sort of these observations of events that occur over time. And they knew when male circumcision was introduced into these communities, and they knew when ART was introduced into these communities.
HIV treatment.
HIV treatment.
Yep.
And so they could ask the question: is there a population-based correlation between the introduction of these modalities, these treatments, over time, and a decrease in the transmission rate or incidence of new infections over time? So what they did is they took all the information, all of the data that they had collected starting in 1999 to 2004, when male circumcision and antiretrovirals were introduced, used that as the baseline, and then started to assess the incidence of new infections from 2004 to 2012. And of the 33,000 participants that are regularly followed in the community cohort study, they identified 17,000 HIV negatives. And those were the ones that they followed over time. And that comprised, I think, 94,000 person years of observation. They followed these people, and in essence, they made a number of observations. One was sex behaviors, and they showed that sex behaviors, initiating sex or not initiating sex,
delaying the onset of
sex. Sexual debut, I think is what we call it, increased over time. So the public health messages were getting to these communities. So between 2004 and 2012, there were fewer initiations of sexual debut in the younger participants.
Can I interrupt you for a second?
Sure.
Can you say why 2004 is so important?
Well, that was really the start of PEPFAR, or the start of the PEPFAR initiative in this particular part of Uganda.
Which is when all the drugs started to
Right. PEPFAR was George Bush's
President's Emergency Program for AIDS Relief.
Is when large-scale access to public sector HIV treatment happened in much of sub-Saharan Africa and around the world, really.
Right. In terms of the other sex behavior changes over time, the number of multiple sexual partners really didn't increase or decrease over time, and condom use pretty much was the same during this period of observation. So in before 2006, there was no antiretrovirals available. In 2006, 12% of the participants were taking antiretrovirals, and by the end of the observation period, the intervention observation period, 69% of people were taking antiretrovirals. The amount of viral suppression was at 40% in 2009, 3 years after people started taking antiretrovirals, and increased pretty remarkably to 75% viral suppression amongst all of the participants followed in this cohort in 2016. And male circumcision rates also increased really dramatically. So in 1999, 15% of the population of men had been circumcised. That increased to 20% in 2006, and 60% of the men who were participating in the study in 2016 had been circumcised. And the bottom line is, when they looked at HIV incidence, they showed that it was essentially stable up until about 2005 or 6, and between the period when the intervention commenced to the end of this observation period, 2016, there was a 42% decline in HIV incidence. And it was greater, this decline was greater among men than it was in women.
It's a really striking change over time that you're observing. I did want to make one more comment before we get into the details. That 70, what'd you say, 75% virally suppressed number?
Right.
Is a really impressive number.
Really impressive.
The UNAIDS targets for countries is they have this 90-90-90 targets, which say that we want to get 90% of those who are infected to know they're infected, of those 90% onto HIV treatment, and of those 90% virally suppressed. So you multiply 90-90-90, you get 72%. 72% is the target, and that is what the world is trying to reach, under the theory that if we get to that number, the infection rate should start to drop. I don't think that necessarily gets us to the elimination phase, but infection rates should start to drop. And so this is an incredible feat that they've actually gotten to. Most places in the world, at least places that we're working, haven't gotten to that number. Botswana seems to have gotten there, possibly Swaziland.
But I think it's important, and we'll talk about this in the second segment. It's probably more achievable in this setting because this community of people has been being studied for 12 years now. So they've gotten the message over and over and over again.
Yep. So Chris, talk to us about your thoughts on this study. Do you think that they have really demonstrated that this is the result of combination HIV prevention, so an increase in male circumcision rates and an increase in viral suppression amongst those with HIV that's led to this incidence drop, or are you not convinced?
No, I'm fairly persuaded that they did.
Even though it's an observational study.
Even though I guess we would probably call this an ecological study, right? Because we're not looking at individuals.
We're going to have to come back to that.
Yeah, why don't we come back to that?
I think we sort of are and we sort of aren't here.
Because there are elements where it's an individual study because they're following non-infected individuals over time. But then they're not looking at those individuals to see, of those individuals who they followed, how many of them were, circumcised, how many of them were...
Well, they actually are in some of their analytics.
Let's come back to it.
It's a little difficult. It's one of the problems I actually had with this study.
But, in a way, the study comes down to sort of three sequential questions. One is, assuming that the interventions, are efficacious, and we can say that, if condoms are used, they are a great way of preventing HIV, but the problem is that they're often not used. And Don alluded to that earlier, that the weakest point of this was that their ability to change sexual behaviors to a lower risk profile was relatively poor, with the exception of delaying onset of sex.
Relatively poor, and even when you get to delaying onset of sex, I mean, hard for me to know what that really means, given that the message of what you're supposed to be doing has been going on to these communities for 15, 20 years. People know what they're supposed to say, and right. So is this increase in debut of onset real?
But the other two things that are part of the intervention are categorical, which is if you are HIV, are you taking ARVs, and if you're taking ARVs, are you undetectable?
And we can measure that.
And we can measure that.
Yep.
So it's not a matter of opinion or self-reporting bias. And the third is circumcision rates, and that also is not really susceptible to many biases.
That was self-report. They did not do an examination.
I guess they didn't check, but I would assume that people are...
I disagree.
You think that people are misreporting their circumcision status?
No, in fact, I use this as a teaching example all the time. If you look at the studies that looked at the relationship between... That is Chris slurping down some lovely tea, by the way.
It's very hot.
I just want to make sure people know that's not me. If you look at the studies of circumcision and whether or not it prevents acquisition of HIV in the observational studies prior to the randomized trials, the studies that use direct observation of circumcision status found a 50% reduction on average. If you look at the studies that didn't, they were all over the map, largely finding no effect.
Well, I'm gonna say my cynicism is found a new low. I mean, I for years I have been sort of beating the drum that self-reported behaviors in medicine are very unreliable. Like when it comes to medication adherence, self-reported adherence is.
I take all my medication, Chris.
Very woolly,
Dr. Chris.
Yeah, so do I.
Yeah.
But I had sort of assumed that circumcision was less vulnerable.
No.
So wow.
No.
Okay. All right. Well, let's assume that they did.
Can I just say one thing? Because
let me finish the logic here, though. Go ahead. So assuming that they do the things that they're supposed to do, the question is: does the HIV do the changes align? In terms of these three sexual behaviors, ART use, and undetectable viral load, and circumcision rates? Do those changes in the population align with changes in HIV transmission? And
as the behavior, the viral suppression goes up, as circumcision goes up, does incidence come down of HIV?
Right. Now, of course, it's tricky because you can have two events that are going in directions that you think are plausible, and they may be totally unrelated. And I think you're going to give us some beautiful examples of that in part two. Part three, because I saw them on the printer yesterday or the other day.
Yep.
Yeah. And so at least there's plausibility that the two are going in the same direction. But the third one is how exactly did these changes come about? And actually, I think here is where the evidence becomes particularly stronger. And what I mean by that is that with combination prevention, you're saying if A is effective at reducing HIV and intervention B is effective at reducing HIV, then in theory, A and B might be even better. And so within their data set, can you show, evidence that A and B are better than A alone? And actually, there's sort of a nested natural experiment in here because of the circumcision. So women do not directly benefit from male circumcision. They may indirectly benefit because if men are not infectable, they can't then transmit later. But it is a delayed effect. So it's
They've modeled that as 10 years later.
Right. So and there's supposedly a delay in that.
Yep.
So if that's true, then whereas ART can be given, the benefits of ART are irrespective, antiretroviral therapy are irrespective of the circumcision status of men. Those are totally unlinked behaviors. If you are a circumcised man in this population, we would predict that the benefits would be greatest to you because you've been circumcised, and there's the community benefits of antiretroviral therapy protecting you. So there are the things that the circumcisions renders you personally less infectable, whereas the antiretrovirals render people around you less infectious. And so you have two wins. And conversely, you would think that uncircumcised men and women would benefit less from combination prevention because they don't have the benefit of circumcision. And that is exactly what their data show.
Yep.
And so I thought that was a really powerful argument that made me think that, I think this is probably true.
Yep.
Let me just get back to the issue of reporting, because the authors actually address that. And in the statistical analysis section, they say, participant-reported use of ART in the cohort has been validated previously by the detection of antiretroviral drugs in plasma with a specificity of 99%. And a sensitivity
so say that in normal people words.
So
use your big boy words.
What they did was that they compared what they said with what they found in the blood.
Yep.
And 99% of the time, when they found it in the blood, the person said that they were taking it. And 77% of the time, when they said they were taking it, it was also found in the blood. So there were more liars in one direction than the other, but still both fairly high. That's a pretty high concordance.
Right. But
hold on. And then male circumcision coverage at a given visit was defined as the percentage of men who reported having been circumcised. Participant-reported circumcision rates have been validated previously from clinical records with a specificity of 100%. But they don't say what the sensitivity is. But it'd be really hard to do sensitivity in that situation.
So what you're saying there, Don, aligns really, really well with the self-report adherence literature, where if patients say that they are taking antiretroviral therapy, right, they might or they might not be, and it's really hard to know. But if they say they're not, they're not.
It's social desirability.
So smoking status is reported on a birth certificate. Smoking during pregnancy as reported on the child's birth certificate. If you say you're smoking during pregnancy,
you probably are.
There's a good chance you are. But if you say you aren't, we don't know what that means.
Who knows?
Exactly. We don't know what that means.
Right. Exactly.
Okay. So, Chris, let's go back to this issue of what kind of study design this is, because the word ecologic, as far as I can tell, doesn't really come up much in this. The word cohort is used constantly throughout this study. So the question is, what kind of study is this? So a cohort study is the kind of study we've talked about many times on this podcast, an observational study in which we simply observe what people do. We follow individuals forward in time, or occasionally we do it retrospectively, and we try to look at the relationship between the exposures and the outcomes. With an ecologic study, we don't do that. We say, let's just look at the rates of things that are going on in a population. So what proportion of the population are circumcised? What proportion of the population have HIV? And we try to correlate those two. And those kinds of designs are often really, really compelling, but not always correct, because two things can, be going all in the same direction. Doesn't necessarily mean that one is causing the other. I found this study really difficult to understand what kind of analysis they're doing, because they do have individual level data. They do an analysis in which they look at whether those who are circumcised are less likely to become infected than those who aren't. But we already know that is true. We know that you're less likely to become infected if you are circumcised. But you can't do the same analysis when it comes to viral suppression, because I can't look at whether or not you become infected if you take the treatment, because you're already infected. I have to look at the people who aren't infected, and therefore that sort of by definition is an ecologic kind of analysis. So if other people are being treated for HIV, am I less likely to become infected? And in those kinds of analyses, it becomes tricky to suss out causation, though I will say the evidence is really compelling. Mm-hmm. Things are certainly, and we have plausibility, right? We know that these two interventions both work. We just don't know whether or not they work on a population level to reduce incidence. So if you really wanted to find out the answer to this question, you would find a population in which, or probably do this as clusters, you'd probably find a couple of populations. You'd randomize some of them to have the combination intervention and some of them to have none of the intervention, or maybe one or only one, and you would compare them. There's no comparison in this group. The comparison is to earlier time points when there was less of these combination measures. And it's unlikely maybe, but let's say it's plausible that other things could be going on that explain these time trends. So say, for example, and let me be very clear, I don't believe this is what's happening, but let's say that what's actually happening is people are underreporting their behavior change over time, such that what's really happening is people are getting the message and everybody's using condoms all of a sudden and delaying their onset of sexual debut and reducing the number of sex partners. And that's why HIV incidence is dropping. It just is a coincidence that at the same time, this is happening at the same time that everybody's getting treated for HIV and circumcision rates are going up. Again, I don't believe that's what's happening. I'm just trying to make the point that when you look at ecologic analyses like these, it's difficult to determine causation. I don't believe that's what's going on here because these two interventions have the plausibility, but I'd say I'm not convinced it explains all of what's going on here for the reasons that I've mentioned.
I have another theory, and if you look at some of the data that's presented in the appendix, and they look at each of the 12 surveys that was done,
Chris in the appendix.
Chris has no idea that there is an appendix.
Yeah,
I saw that.
There's a really good appendix. So
Chris
what they do
went
is
right past that.
So what they do is they look at the number of people who, when they showed up at the house, were away or for work or at school. And in the beginning, there were 18% of the people who were not at home when they came to the house. Whereas at the end, it's in the range of 30%. And so that sort of suggests that there might have been some what we call out-migration of individuals.
Definitely.
And the question really is, is there a difference in the people that out-migrated than people that didn't? And if you look at one of the other pieces of data that they present in the appendix, what they did was they broke down the incidence among
of
people,
HIV.
Incidence of HIV among people who had sex with individuals outside of the cohort, i.e. perhaps those people that out-migrated. And for women, the incidence was, from what I can tell, about 16-fold higher if they admitted to having sex with, hold on a second, it's 1.46 fold 46% greater if they had admitted to having sex with people outside of the community.
That's a much more reasonable number.
That 8.63 was in fact for more than three partners.
So it enhances your trust in this? Is that what you're saying?
So no, what I'm saying is that the people who out-migrated might have been more sexually active and therefore had a higher incidence. And maybe some of the incidents that we're not seeing in the people that are staying home is because the people at higher risk started having sex with people outside of the cohort. That's another explanation.
I agree. Another one is that their participation rates in their survey looked to me like about the high 60s fraction participation. Now that's
not super duper.
No, it's not. Now I'm not clear on whether or not that pertains to the actual HIV incidence data. In which case, it may just be people didn't want to participate in the survey, but they gave the blood sample. We have information to be able to determine the correlation between incidence but since the circumcision data is self-report, I have to believe that that's where that's coming from. These things are hard to do, and I will say this group has done an amazing job at doing the research in this place for decades. I think it's actually longer than what you had said. I think it's like 17 years they've been there.
Since 1999.
1999, so 18 years. Really an impressive amount of work.
Lots of really important research has come out of this group.
Incredible amounts of amazing work. So to get 60, you only get 64% in the survey, and I will double check that number, but it's kind of what happens, but it does mean you have to sort of take this with a little bit of a grain of salt. Again, I'm not saying that correlates to the numbers that they have data on for the HIV, in which case it may not matter, but it wasn't clear to me. Any other, and I will say, by the way, this if you actually go to their discussion, they actually make the point in their limitations, they say we cannot rule out the possibility that unmeasured secular trends or other potential confounders explains the declines in incidence of HIV infection. So in other words, they can't, one thing we know about Uganda is the HIV incidence rates were dropping well before HIV treatment came along. Now they do appear to have leveled out at the time that this study is going for. So I'm not trying to say that explains what's going on here, but it is something when you're doing this kind of study, you have to pay attention to other things that could be going on when you don't have a comparison group.
Yeah, right on. I agree.
All right.
But overall, I'm.
But overall, a really compelling piece of evidence.
I'm inclined to believe this, and it all sort of hangs. And I think you're gonna give us some.
And just
you're going to do the wacky weirds?
Yes.
Okay.
One of the other things that I think is notable, I can't find it actually the specific information, but they allude to the fact that modelers have indicated that we'll have to get the incidence down to 0.1
per 100 person years.
0.1 per 100 person years if we want to eliminate the infection. And this is as good a shot as you're going to get with the current tools. So I think it really underscores...
And with a population that is so under surveillance.
Right.
And they only got to...
So this underscores the need really to continue to do research and to develop even a partially efficacious HIV vaccine.
Yep.
Yeah.
Yeah, just to clarify, you have to get to 0.1 per 100. They got to 1, I believe.
0.6, I think it was.
0.6. Sorry, 0.6. Sorry, they started at 1. They got to 0.6. You got to get to 0.1 to really think about elimination.
Yeah, you did. But
that's right. It's going to be said twice. It's an important point.
But we're not there. In other words, we're not there.
Can I just make a point about the incidence dropping to 0.6? No?
Yeah.
All right, never mind.
No, go ahead, Matt. Go ahead. You got time.
You got to get it below 0.1.
Yeah, but it's sobering, right?
Okay.
I mean, that's the point. That the best we have to offer
really hard to do.
It's super hard to do. It's super logistically intense. It's only partially effective, and it's not enough.
Okay.
But we've saved lots of lives.
Lots of lives.
It's really impressive.
But we're not going to treat our ways out of this epidemic, is what this data say.
It says it's going to be really hard to do. And in fact, there have been other trials that have actually gone about this in a trial-rated format, test and treat studies, where we try and take everyone who we test for HIV infection, who test positive, and put them on a treatment. And some have been shown some promise, and some have actually shown no benefit.
Really good work out of South Africa on that, from what I understand.
Really good work.
Yeah.
Really, yeah.
Those guys are heroes.
Can I? Thank you. Can I just end by making the point, though, that I much as there is plausibility in this, it's also not clear to me that we know exactly what's going on. And I think the way that, to me, that it was very clear was I started noticing a pattern when I was reading this study, which is there was one particular word that seemed to keep reappearing more than I would have expected. And the word was probably. They don't make a lot of strong statements here. They say probably, which actually... Probably more of our studies should say this, but the word probably featured 8 times in this.
You counted
in this study. You want to know how many times it's appeared in all of the previous 13 studies we've looked at?
You actually sat down and counted that word in every...
I did a search. I didn't actually.
You got to get out more, man.
What do you think it is? I've got nothing going on a Saturday night.
3.
7.
Oh, really?
7 times in the previous 13 studies.
Oh, total.
8 times in this current study, which I think, again, it points to the fact that they are making the statement that they don't know exactly what's going on. This is ecologic data, and we should be cautious, and I think it's appropriate.
That sounds probably significant.
I think it's probably the right way to go.
Just to sort of segue off of the issue about media bias and media reporting. So when you were looking at the media blurbs about this, did you? I mean, because what you're saying is that they were particularly conservative and cautious, and appropriately cautious in this. Did that come through in the stories? Did you notice that?
Okay, so now you want me to pretend that I read past the headlines? I cannot answer that question. I pulled the headlines.
All right, well, let's take a peek afterwards. We
will do that. Okay, so let's move on and. To move into our second segment, we're going to get into this idea of the difference between efficacy and effectiveness studies, which are 2 different ways of measuring how good a particular intervention is at whatever it is we say that it's going to do. So, get us into this, Don. Can you explain to us what the difference is between an efficacy and an effectiveness study, and tell us whether you think that this particular study that we just looked at is looking at efficacy or effectiveness?
So an efficacy study is a study that is where you have an intervention and you're looking for some outcome from that intervention, and you're doing it in a very controlled way, and you're controlling all of the possible variables under highly rigorous scientific conditions. And
as much as you can.
As much as you can. And you find an effect. And then the next step is to take that same intervention and sort of apply it to the real world. And applying it to the real world, or I think some people call them pragmatic trials, are the next step to show that, in fact, in the real world, outside of the very constrained circumstances of a clinical trial, you can show that, in fact, it can work, and that would be an effectiveness study.
And so, which one would you say this is?
I think this is sort of a quasi-effectiveness study, because it's as we were describing before, it's not really reflective of kind of the untarnished real world or the tarnished real world. It's a community of people that have been studied intensively for the last 17, 18 years, and so it's got limited generalizability in that regard. But it also is it really is looking at the effect of these sort of almost population-based interventions. So this is a weird hybrid in my mind.
Yeah, and I think it's a little unfair for me to even ask the question in the sense that typically when we're talking about efficacy and effectiveness, we're really talking about randomized trials where we think about this more. But as you say, we're getting at the difference between real-world conditions and the control conditions. So why would we ever even want to do efficacy studies? Why would we ever want to do these studies that don't actually tell us about what's going on in the real world? What's the point?
Well, I mean, an effectiveness study, if you're going into the real world, it sort of implies that the medical community has gone beyond asking whether this thing works, and now they're trying to make it work in the real world. And those studies tend to be very, very large, and they have already sort of permeated into clinical care. What we don't want to have happen is that we introduce interventions that don't work and then permutate, and we only learn that they have they don't work in an effectiveness study. We would like to know that the intervention itself in an ideal setting has some potential benefit. Now the question is, can you make that work outside of an experimental setting? And
I agree. And I just to sort of clarify what you're saying there, I think we want to be very careful to not do an effectiveness study, which is effectiveness meaning we're doing this in the real world conditions for an intervention that might actually be effective. It might actually, or efficacious, I should say. But we don't learn that it's efficacious because the conditions under which we use the intervention aren't right. And so we want to know first, under idealized conditions, can it work? Mm-hmm. And then we want to move to the situation where, okay, is it going to work in practice? And I think this is part of the problems that we run into with randomized trials is the results are often, show benefit, let's say, of some new drug, but the population that's been under study has been really coached very hard to continue to take the drugs despite any side effects that they might have. We don't lose anyone from the study because we really do an intense job in following them up. We provide them with some incentives and some compensation for their time, for being in the study, and for doing. And the people who volunteer for these studies are often healthier than the average person who wants to be in a study, or in some cases, you can make the argument they're probably even sicker than the average person because they're really clinical trial is really their only option left. So we don't always know, based on the results of efficacy studies, whether or not these things are going to work, and we want to test them out under both conditions.
Right. I mean, you can sort of tick off the list of things that are different in the real world from, the context of a closely monitored clinical trial. You in a clinical trial, of any drug, you're going to have some team of study nurses or assistants who contact the patients on a regular basis and make sure they're taking the drug. And in the real world, patients don't take the drug. Their adherence much lower than in efficacy studies. In a clinical trial, you've got a procedure like some new ultrasound test for diagnosing liver cancers, and it's very tricky to do, and you have to train the radiologist really hard to do that, and then they take special courses, and they have quality control, and people are making sure that they're right, and there's a gold standard, and there's an adjudication process, blah, blah, blah. And in the real world, none of that exists, and so the radiologists are just not as good at identifying liver cancers using this new ultrasound test because they don't have all of those supports, and so it doesn't work as well. Yeah. And you just keep going down the list of the things that sort of start to sort of become fuzzier, and patients are assigned to take this medication and not that medication, and in the real world, they change their
both.
minds
They
and
take
go
both.
and take the other one, or they take both, or they take neither, and they don't tell you, and you have no idea what's going on. And so it all starts to tend to, migrate towards the null because, the exposed and the unexposed groups start to look disturbingly similar in terms of how many people are actually taking the drug.
Or the compliance is very different from what you see in the trial,
Exactly.
or the side effect profile starts to become more obvious.
And the logistic limitations of these interventions become more apparent because, it turns out that, here's this fantastic drug that comes in liquid form and can't be exposed to ultraviolet light and has to be stored at 4 degrees, and it has all these toxicities you have to monitor for it. And then, you're going to try to ship that, to a rural setting in Zambia. And it turns out that by the time it gets there, it's been cooked in the 4x4. None of it works. This is why oxytocin is so hard to implement in low and middle income countries, even though it is a life-saving drug.
Highly efficacious for
postpartum hemorrhage, but very difficult to get an oxytocin drip into a rural village in Zambia.
Mm-hmm. Do you think that then we put too much value in efficacy studies, that when we find some new thing is beneficial, that people, particularly media gets very excited about these things, we as researchers get excited about these things, when they have yet to be demonstrated to actually work under real world conditions, and maybe we are overhyping the benefits of the particular interventions that we are looking at?
No, I don't think so. I think we need to be a little sanguine about it, but
Define sanguine for those of us who failed the GREs.
We have to be a little cautious.
I didn't fail. I just didn't do that well in the English part.
Because when we are able to establish that an intervention is efficacious, it's a new finding and it's a new tool potentially, and it's something that really moves us forward. And whether it's going to be borne out in the real world or not remains to be seen. But I think the excitement is warranted, but needs to be tempered some.
Yeah, and I would agree with you. And I would just say I think we need some caution because when these new treatments come out, they often look phenomenal, and that gets people really excited and lots of hope. And we should expect that in many cases, the actual benefits under actualized conditions are not going to be as great as we think they are. And so, some caution is warranted.
Yep.
The word probably should probably be used
At least 8 times.
At least 8 times.
I think you're probably right, man.
I think I probably am. All
I
right.
think that's a probabilistic statement, though,
That
isn't
is.
it?
All right. Well done. Okay, so let's move on to our last segment, our amazing and amusing, where we want to highlight some of the things that make us enjoy our jobs even more. Look at the weird, wacky things that go on, as well as some of the things that inspire us, which is why it's called Amazing and Amusing, Don, in case you weren't listening. It's not wacky science.
I never listen, Matt.
I know that's true. And I'm going to go first today because mine actually relates to the topic that we were talking about during the first study, which is this issue of ecologic studies not always being able to tease out the difference between correlation and causation. So as we said with the Uganda study, we have this study which shows really nicely that over time, as the rates of male circumcision go up and the rates of viral suppression go up, the rates of HIV incidence come down. And that's, makes sense to us, and it's intuitive, and therefore we want to believe that's true. But we have to be careful because we know there are cases where correlations that look really good aren't exactly causation.
Spurious.
They are spurious correlation, excuse me. So there is it was originally, I found it on a website, but it has now been made into a book by a guy named Tyler Vigen. Vigen? I don't know how you pronounce it.
Vegan.
Whatever it is.
He's got a very correct
So
diet.
this is a plug for his book, which apparently you can get on Amazon, Barnes & Noble, and other sites, which just looked at a whole bunch of what we presume are, which look to be incredible correlations over time, which presumably we don't actually believe are in fact causation. So let me give you an example.
So this is a situation where if we had a website, we could post these figures on the website because the figures are really impressive.
I think we would link to it. I don't think we're able, but we have a website.
Do we?
We do have a website. That's on www.pophealthyx.org.
Oh, really?
Have you not heard me say that? 1,000 times?
I had, but I thought it was static. I didn't think we could actually post things on there.
So what we've got here is...
The frequency of you making that statement does not correlate with Don's interpretation of the
Disagree.
It's an inverse correlation.
does not equal causation.
No, disagree. Perfectly inversely correlated. The more times I say it, the less
likely
he is to remember it.
Because he's stubborn.
Okay, so what these show is graphs over time. So from 2000, let's say, to 2009, and they just plot the yearly values of certain things. And the correlations, just to look at them, you can tell are amazing. I mean, he does actually calculate the actual R-squared values, and they're in the 95 for range. So, for example, really good correlation. Number of people who drowned by falling into a pool correlates incredibly well with the number of films Nicolas Cage appeared in. Certainly must be causal. Murders by steam, hot vapors, or hot objects correlates incredibly well with the age of Miss America. And last but not least, the number of people killed by venomous spiders correlates incredibly well with the number of letters in the winning word of the Scripps National Spelling Bee.
No.
Incredibly correlated.
Let me see that.
Yeah, really impressive stuff. So my point
Those
there
spiders,
being,
they are so bad.
There's got to be a connection.
I've been saying this for
There
years.
has to be a connection.
What's the Chris is
National Spelling
notoriously
Bee, which is
arachnophobic.
National Spelling Bee, from the insect kingdom,
Bee.
and the venomous spiders, insect kingdom.
Ah,
There you go.
Don has figured it out. Anyway, if you go onto his website, tylervigan.com, or you buy his book, there is so many more of these, and they are fantastic to read through. Chris, you wanna tell us what you got?
Yeah. So in my search today, I found another article that was a little bit of a downer, actually.
That's not what we do on this segment.
I know, but interesting. This is another article from PLOS One, which I just want to put a plug for. I really think it's a great journal. So I'm just going to say, I think PLOS One is a terrific journal.
It's the Public Library of Science.
Public Library of Science. The articles.
At some point we should talk about them as a model, because they have this really interesting philosophy where they do not assess the importance of the studies that they publish, only the quality.
Yeah, I that's why I think that they get many stars from me. Well, this article is called "Facebook Use Predicts Declines in Subjective Well-Being in Young Adults."
Oh boy!
And it's by Cross and colleagues at the University of Michigan in the psychology department. And they did a very interesting observational study where they built they assembled a little patient cohort. They followed them for 14 days, and every day they sent them 5 different text messages at random times. And the text message included a hyperlink to an online quiz. And on the online quiz, they were to, at that moment, report their recent use of Facebook as a proxy for digital social interaction, their actual social interactions with real, walking, talking people, as non-digital, like the old school form of digital of human interaction.
Can you just text me the answer to this one? I don't actually want to listen.
And then they also measured their affect in 2 different ways. One was how did they feel at the particular moment in time, and then the other one was how did they rate their sort of general quality of life. They also looked at their degree of loneliness and their degree of sort of worry, anxiety about the future.
Oh boy!
And they found and they did a very sophisticated. I wouldn't say very, but they did a rigorous statistical analysis where they did lagged analyses, meaning does Facebook behavior on Monday predict the way you're going to feel on Tuesday? Mm-hmm. So they're always sort of looking forward and trying to relate the recent behavior with the current state. Okay, which I thought was a nice way of approaching the problem, and basically what they found was a little bit sad, which was that people, that the more that individuals use Facebook, the sadder they felt, the lonelier they felt, the more they sort of described their mood as being low, and the more that they felt sort of discouraged in their life, and these effects were rather strong and statistically very, very tight. So it was compelling, and then they did a whole series of analyses to sort of probe the alternative hypothesis, what else could this mean? One hypothesis is that maybe it's not Facebook interactions that are bad, maybe it's all human interactions that are bad, and just being with people makes you feel bad.
somehow
I
got
could
that.
say that's possibly
I
true.
can't understand why you got cut down or cynical based on this paper.
Anyway, so they looked at the direct social interactions, and they found that actually they had the opposite effect. That the more you talked to people and interacted with people, the better you felt.
Yeah, I believe that.
And so then they said, well, maybe it's just that lonely people use Facebook, and it's sort of like a descriptor reverse causation. So
Chris's favorite.
So they looked and said, indeed, lonely people do use more Facebook. So that was true. But then they put the loneliness into their statistical model, and after adjusting for the loneliness of the person, they still found that the increased use of Facebook.
The lonely people got lonelier.
They got lonelier and sadder the more that they used Facebook. So even after adjusting for that sort of baseline characteristic, they still found that this was a downer.
But couldn't you make the argument that sort of Facebook constitutes an idealosphere? Where people post pictures of things ways in which their lives are just wonderful and the kids are happy
and it's very discouraging
animals
to
are
see.
happy and I would think that many of those people's lives, when you really scrutinize them, are far less ideal than they appear on Facebook.
I must be an outlier because I look at Facebook and I think, boy, my life is great. No,
You must have really.
I'm kidding. I don't actually use Facebook very much at all. I'm just kidding.
Or
Just kidding.
Twitter. To me, it's like
Twitter? No, Twitter's different.
For me, Twitter is the bickerosphere. It's like all people do is they just bicker back and forth.
Yeah.
So they ended their paper with a really nice quote, which I'm just going to read here, and it says. On the surface, Facebook provides an invaluable resource for fulfilling such needs, and they're talking about human interaction, by allowing people to instantly connect. Rather than enhancing well-being, as frequent interactions with supportive offline social networks powerfully do, the current findings demonstrate that interacting with Facebook may predict the opposite result for young adults. It may undermine it.
Bummer.
Yeah, so I thought a cautionary tale. And I don't know. I have to say it does kind of jibe with my own experience with it. That it tends to leave me feeling pretty dry.
I predict Chris does not delete his Facebook account. You want to take that bet?
No, I'm not going to take that bet.
All right, off to you, Don.
So
thank goodness I didn't end with Chris.
God, on that happy note,
bummer.
Wacky and weird.
That's like the Prozac section. What I've got is we discuss science, we discuss papers, we discuss methodology and background and analysis. We never discuss the acknowledgments section
we really
of papers.
don't.
And I didn't realize that, but there really is just a whole world within the acknowledgement sections of scientific papers. And so I'm referring to a paper that an article that appeared in Slate in 2013 by Meredith Carpenter and Lillian Leyland, entitled "The Snarky, Clever Comments Hidden in the Acknowledgments of Academic Papers." And they come in several categories. So these
are actual scientific papers where somebody put something.
These are quotes from within the acknowledgement sections, which is written in like 4 font at the bottom of the title page of scientific papers. So the first category is sticking it to the man. So I'll quote the section in this acknowledgement. It's BJH would also like to thank the U.S. Immigration Service under the Bush administration, whose visa background security check forced her to spend 2 months following an international conference in a third country, free of routine obligations. It was during this time that the hypothesis presented herein was initially conjectured.
Well done.
And then second one is, I thank the National Science Foundation for regularly rejecting my honest grant applications for work on real organisms, thus forcing me into theoretical work. Then another one is the order of authorship was determined by proximity to tenure decisions.
Oh, yeah. Okay.
And the order of authorship was determined from a 25-game croquet series held at Imperial College Field Station during summer 1973. And then thanking nature is another section. We're quite familiar with this. The authors wish to acknowledge Snowpocalypse 2010 for making the long-awaited completion of this paper possible. So that was a period of time in Boston when there was snow unremittingly
What was it? Was
for 6 weeks or something.
2014 or so? Where, I mean, you couldn't drive in the city of Boston. All 2-lane roads became 1-lane roads. The snow pile in the center of Boston finally melted in July. You can go on and there's a time lapse of it that is phenomenal.
Yeah, there was something else.
Yeah, that's when they had a pool for when the last little bit of snow would finally disappear. And it was like July 30th.
And the other thing
30th
is everybody in the city of Boston was miserable.
I know.
You get into an elevator and fist fights would break out.
So it was a 3-hour commute to get home.
Yeah. Oh,
The thing that I remember
God.
was the mayor requesting that people who lived in the city stop jumping out of the second floor windows, spread eagle onto the snow below.
That was the year they put a moratorium. Moratorium, is that the right word?
Yeah.
On the ban on the people would shovel. People in Boston shovel out their parking spot, and then they put furniture in the space to own it.
Right.
And they
and you
the
dare
city,
not move that furniture if it's not your space.
Correct, but the city will come along and take that. But the city said at that point, we are going to allow it. That was anyway. Continue.
All right, so the last section are unacknowledgements. So the first one is we would like to thank Carla Miller for sleeping late one morning, leaving Tim and Steve a bit bored, and Saad for making the brains look pretty.
Nice.
And then the last one is we do not gratefully thank Tim Aporshak for his useless and very mean comments.
Well done. I wish I had the guts to do that. I have to say, more and more journals now require you to get permission from people to acknowledge them, which is going to ruin that because who's going to want to
taking all the fun out of life?
Yeah, how are you going to get a signature from Snowpocalypse? Boy,
Regulations.
Yes. All right. So you've made it to the end of our program. If you got any feedback on this or any other episodes, or you want to suggest a study or a topic that we should take on, tweet us at @PopHealthyX, or you can tweet me at @ProfMattFox, or Chris at id.gill, or Don at @dthea1, or you can find us on the Population Health Exchange website at www.pophealthyx.org. We'd like to thank Leslie Talalian, Director of Lifelong Learning at BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you download our next episode.